everyone. My name is Ben O'Dell, and I'm with the Partnership Center for Faith and Opportunity Initiatives at the U.S. Department of Health and Human Services. We are so very glad that you have joined us today for the fifth webinar in a series of webinars featuring community leaders talking about the innovative and promising practices they are implementing across the country in response to the opioid crisis and the need to support those struggling with substance use disorder. Today, we get a chance to hear from some amazing speakers, including Annette Waters from the Office of Assistant Secretary for Planning and Evaluation here within HHS, as well as Jill Kingston from Bridget's Path in Ohio, and Lori Corrier from The Call in Arkansas. As a part of the webinar today, you will gain a sense of the nationwide challenges being experienced in the child welfare and foster care systems as a result of the opioid crisis, understanding about how the opioid crisis is affecting our kids, including babies born to mothers who have used opioids during their pregnancy, and how faith communities are joining with the child welfare system to address the increasing number of children coming into the foster care system related to substance misuse. So we have an exciting and informative program today, and I will more fully introduce our speakers in a moment, but first, a few housekeeping notes before we begin. This is an educational webinar off the record and not intended for press purposes. If you're a member of the press, we'll be happy to connect you to the press office here at HHS after the program. While we do have a full program today, we welcome your questions and comments throughout the webinar, and you can place them in the box for questions in the lower right-hand corner of your screen. We hope to share as many questions as possible with our presenters during a brief Q&A at the end of the program. Also, if you're having difficulty with your audio, you may find it helpful to call into the number on your screen rather than listening through your computer. We have found that sometimes that works better for improving sound quality for those who participate. And as a final note, we will be sending a link to the recording of today's webinar and a follow-up email to everyone who registered for the webinar, along with links to resources and information highlighted by our presenters. So look for that in the next day or two. With 116 Americans dying every day from an opioid overdose, yes, we are in the midst of a critical, acute crisis. For some of those who pass away, there are children whose lives are forever changed if they lose a mother, a father, or a guardian who pass away as a result of an overdose. There are also those children who are born with a group of conditions caused when a baby withdraws from certain drugs he or she has been exposed to in the womb before birth, since the mother struggled with addiction during her pregnancy. These children are the unintended victims of the opioid crisis, and their numbers are rising. As an example, an infant is born every 15 minutes with those withdrawal symptoms called NAS symptoms. As a part of our presentation today, we're going to hear from HHS about a national study that looked at these increasing challenges for human services that are occurring as a result of the opioid crisis. This study paid particular attention to the challenges in the child welfare system, and today we will gain a better understanding of some of those challenges. To share that data, we get to hear from Annette Waters. Annette is a senior social science analyst in the Office of Human Services Policy in the Office of the Assistant Secretary for Planning and Evaluation. Annette conducts both quantitative and qualitative research on low-income populations and the social welfare programs that they use. She is currently the project manager and statistician for the research projects we're going to hear about today, focusing on the intersection of the opioid crisis and child welfare. Prior to working in ASBE, Annette was a statistician and demographer in the U.S. Census Bureau. She has her PhD in sociology from the University of Maryland at College Park, where her dissertation was on social capital and women's employment. She was a postdoctoral research fellow at Princeton University, and she's also worked as an ethnographer in the U.S. Housing and Urban Development Moving to Opportunity program. So while the challenges that Annette will share with us are rising, there is good news. There are amazing faith-based and community-based organizations that are stepping into the gap for these children, providing services for babies and their mothers, as well as the children who are entering the child welfare and foster care systems. And while we know there are a huge and amazing number of groups working in this space, we're going to hear from two of those leaders today who are doing work to help us understand the on-the-ground realities of what Annette's going to present from a national level. Perhaps more importantly, they are also going to share how they are seeking to address these challenges and describe what they've learned and suggest how you can implement similar programs in your community as a response to the opioid crisis. So after Annette's presentation, we're going to learn more about how the opioid crisis is even affecting babies through the work of Bridget's Path, a newborn recovery center in Kettering, Ohio. To help us learn more about their efforts, we're going to get a chance to hear from their executive director and founder, Jill Kingston. Jill graduated from Ohio State University with a degree in human development and family science and earned her master's of education degree from Wright State University. After teaching for a couple of years, Jill founded and ran a successful business for 12 years before turning her focus to opening Bridget's Path. She and her husband are parents of 3 school-age children, a preschooler and a toddler, and her family is in their 5th year of fostering babies with neonatal abstinence syndrome, or NAS. After we hear from Jill, we'll get a chance to hear and think about the work. One second. If everyone can put their phone on mute so we limit the amount of background noise, that would be great. After we hear from Jill, we'll get a chance to hear from and think about the work and challenges to address in the foster care system. As we hear from Annette, an increasing number of children are entering the child welfare system connected to the opioid crisis and substance misuse. Faith-based and community-based groups have an opportunity to rise to meet this challenge in partnership with the child welfare system, and we'll get to hear about how one program is doing just that. Since 2001, Lori Courier has pursued her personal mission of positively impacting the lives of the fatherless as the executive director of The Call. Lori puts her spiritual gifting for administration and as a pastor or shepherd to work by leading the expansion and organizational development of that program in Arkansas. Today, The Call has 44 local affiliates statewide and has recruited more than 2,000 foster and adoptive parents that have served more than 10,000 children in the foster care over 9 years. Lori serves on multiple committees and councils coordinated by the state of Arkansas, focused on improving the outcomes for the fatherless. Lori is a 1985 graduate of the University of Arkansas at Little Rock with a BA in English and Communication. She lives in Little Rock and is proud mom to 2 daughters, Katie and Caroline, and grandmother to Shelby and Gray. So now let's turn to Annette and her presentation on some research at the national level about how the opioid crisis has impacted human services and child welfare systems in particular. Annette, excited to hear from you with your presentation.
Thank you. So, can everyone see the presentation? Can you see it, Ben?
Yep, looks great. Go ahead, Annette.
Excellent. So thank you for giving me this opportunity to present today. I'm going to present on parental substance use, opioid misuse, and child welfare. So first, I just want to talk about substance use and the child welfare system. I want to give you an overview of what we mean by the child welfare system. So this data refers to fiscal year 2016. In 2016, 3.4 million children were the subjects of screened-in reports. Of those 3.4 million, more than 70,000 victims of child.
Annette, this is Ben. I'm having a hard time hearing you pretty well. Can you pick up your headset?
Can you hear me better now?
Yes, that's much better. Thanks, Annette. Go ahead.
Okay, so let me begin again. This data is for 2016. So in 2016, 3.4 million children were the subjects of screened-in reports to state child protective agencies. Of those 3.4 million, 670,000 children were determined to be victims of child abuse or neglect in 2016. And of those children, 273,539 children actually entered into foster care. So we were trying to figure out what's going on with the foster care caseload. So this graph shows that in the earlier period, foster care caseloads were higher. They declined, but then again, in about 2012, they started to rise. And by 2016, we saw the increase kept going. So people were wondering what's going on. Why are there so many children in care? And anecdotally, people said, well, it's probably substance abuse. So that's how this project got started. So what we first did is looked at the change in the most recent period, the map you just saw, the graph you just saw, to find out at the county level what's going on. So what we did is we mapped the change in foster care entries between 2012 and 2016. So the dark blue areas of the map are actually where the foster care caseload decreased more than 50% in those counties. And then we see that in other counties there's an increase in the number of children going into foster care. The red areas of the map are where the foster care caseload increased by more than 30% in between 2012 and 2016. So when we say we have a greater caseloads, that's at the national level true, but when we drill down at the county level, we find a mixed story. So what I want to do is now look at the relationship between retail opioid sales and foster care. So this map is showing per capita retail opioid sales from 2006 to 2016. The way we put together this slide is the following. We took the distribution in 2016 and applied it backwards. So in 2006, let me explain the legend. The left column of the legend are the actual number of counties, and the right column of that legend are the relative frequencies. So in 2006, 176 counties, and there are 3,000 counties, more than 3,000 counties in the country. 176 of those of U.S. counties were in the highest category for medical morphine equivalent, or 6% of all counties. And then we look as the time progresses, opioids spread across the country. By 2012, 920 counties, or 29% of all U.S. counties, were in the highest category for volume of medical morphine equivalent. We've had a lot of changes in prescribing, and so by 2016, we have fewer counties in that highest category for medical morphine equivalent. So 782 counties, or 25% of all counties, are in this highest category. So then what we did is we looked at the intersection between prescription opioid sales and foster care. Now, this map does not show or does not say that the children went into foster care because the parents were using opioids. What this map shows is the taste or the prevalence of opioids in a county. And you see clustering. There are some counties, there's quite a bit of opioids and high foster care. Those are the red areas of the map. I'm going to switch to our heat map. So the difference between these two maps is we just stripped off everything but everything that's high opioids and high foster care. And what you see is a clustering of counties. We see it in West Virginia, Kentucky, Tennessee. We see it in Oklahoma. There's clusters where both opioids are high and foster care is high. So now I want to look at drug mortality rates and foster care. And again, we're not saying that the child went into foster care because the parents overdosed. We don't have that data. We're talking about prevalence here. So it's the same methodology that we use for the retail opioid map that we're using for the drug mortality map. We took the distribution in 2016 and applied it backwards. Again, the left column of the legend is the actual number of counties. The right column of the legend are the relative frequencies. So in 2004, one other point of clarification. We don't know what drug the person died from. The coroner's reports don't give us that. We just know that the person died and drugs were a factor in the death. So we can't say, these are heroin deaths or crystal meth deaths. We can't do that. We just know that drugs were a factor. Okay. So in 2004, 19 counties, or 1% of all U.S. counties, were in the highest category for drug mortality. And then we look at how drug deaths spread across the country, that by 2016, 784 counties, or 25% of all U.S. counties, were in the highest category for drug deaths. But I want to go back to the 2004 map. Even in 2004, there were places in the country that were experiencing high drug mortality. So if you look at Appalachia, they've been struggling with this issue for a very long time. And so while we're saying now we do have a lot more drug deaths, in 2016, some other counties have been dealing with this for more than a decade. So this next map shows the intersection between drug mortality and foster care entry rates. Again, I want to just make sure everyone's clear. We're not saying that the child entered into foster care because the parents died of drugs. What we're looking at is the association, the relationship between these these two factors here, and we're not in any way saying that the drug death caused the child to go into foster care. But again, when we say we have a drug death issue, when we look at the county level data, then a different image emerges. So again, I just keep calling your attention to Appalachia: high drug deaths, high foster care. You can look at the Pacific Northwest. Again, high drug mortality, high foster care. The Northeast, again, we see a pattern. And in our next map, this is our, again, heat map for drug deaths. When we strip off all the other colors, we see geographic clustering. So again, when we say we have an epidemic and a problem, we have a problem not in every county in the country, but in specific counties we do have an issue. So the maps that I just showed you are a part of the study that I'm kind of overseeing. So the study is a two-parter. It has a quantitative portion and a qualitative portion. So the statistical analysis is on administrative data for most counties in the U.S. Then after we ran our statistical analysis, we actually went on the ground and talked to people. And we interviewed 188 local experts in 11 sites in the country, and we talked to child welfare administrators and caseworkers. We talked to judges and court professionals. We talked to substance use treatment administrators and providers. We talked to people in public health, and we talked to law enforcement. So there are more than 3,000 counties in the country. What we initially did was look at where there were differing relationships. Like back in the mass, we looked at some high foster care, high child welfare counties. But then we also thought we would look at places where, like, there was high prescription opioids but lower foster care. That was our initial look, because we thought maybe there's some best practices or some innovative programs going on that's kind of keeping the foster care caseload down. So we went from Portland to Salt Lake City. We went to Santa Fe. We went to Tulsa, Oklahoma, and we also talked to the Cherokee Nation. We talked to people in Mississippi and in Tennessee, in North Carolina, in Indiana, in West Virginia. We went to Vermont, and we went to Massachusetts. By the time we actually got on the ground, even places that we thought were, had lower foster care entries, though, because our data is from 2016 and we collected data in 2017, everything was high. So these counties do not represent the entire what's going on in every county in the country, but we tried to do a swath of the country as much as we could to kind of figure out regionally what's going on. And this is what we found. This is at the national, this is at the national level. We looked at drug hospitalization rates and foster care case rates. And what we found is at the national level, a 10% increase in hospitalizations due to drugs corresponds with a 1.6% increase in reports of child maltreatment, a 1.9% increase in substantiated reports of child maltreatment, but a 3% increase in foster care placements. So if it was just more drugs, more people being treated for drugs in hospitals, and we'd expect that all three of the arrows on the right of this graphic would be the same. But that's not what's happening. There are more reports of maltreatment and more reports of substantiated reports of maltreatment, but there's also more children going into foster care. And that is because, as we went on the ground, the cases are more severe, where case workers are saying to protect this child, we must remove the child and place them in foster care. So these are tougher child welfare cases. The other statistical models that we ran were on drug overdose deaths. And what we found is a 10% increase in drug overdose deaths corresponds with a 2.3% increase in reports of child maltreatment, a 2.4% increase in substantiated reports of child maltreatment, but a 4.4% increase in foster care placements. So again, the cases are much more challenging, and caseworkers are making the decision to, or child welfare is making the decision to remove children to protect them because the cases are more challenging. So now we're going to talk a little bit about how substance use affects child welfare systems. After we talked to those 188 people on the ground, this is what they said. For child welfare involved families, it's not an opioid crisis everywhere. Heroin is prevalent and polysubstance use is pervasive. And this is something that is a little bit different in this drug epidemic than we saw in previous epidemics, is that it's not just opioids. It's opioids and heroin and alcohol and a whole bunch of other substances together, which is challenging. The people on the ground told us that lost economic opportunities, poverty, and or trauma underlie the current drug epidemic. We also found that collaboration between child welfare and substance use treatment providers is difficult because they are at cross purposes. Child welfare is primarily concerned or principally concerned with protecting children and child safety, whereas substance use treatment providers, their focus is getting, people into treatment and treatment adherence. So the two systems have cross purposes, and there are challenges of them trying to communicate and collaborate. We found that agencies and caseworkers are overwhelmed and often pessimistic about family reunification. We found that there are lots of cross-state issues in terms of people crossing state borders to avoid child welfare and delivering in hospitals where they're not in a state they're not a resident of, and how states communicate. There are just lots of issues. We also found that communities experience continued treatment shortages, particularly family-friendly treatment. We found that there's an intensifying shortage of foster homes due in part to multi-generational substance use. So in previous drug epidemics, we could find grandma or aunt or cousin or someone in the family to place the child with. But in this drug epidemic, what we're finding is that the family is using drugs. The people that we could rely on before, like grandma's on drugs. Cousin is on drugs. Neighbors are, the community there's a lot of substance, which is making it difficult to find suitable foster homes. And then medication-assisted treatment is challenging to implement in the child welfare context. There's lots of just misunderstanding about MAT, and judges view it different ways, and so that's a challenge. Now, what I've presented is a lot of negative information, but there are bright spots. That's what Ben said. There are programs doing great work, and so I want to first just start off with just a little bit on medication-assisted treatment. It is an evidence-based practice for opioid use disorder, and the Department of Health and Human Services is fully behind MAT. There are 3 FDA-approved medications to treat opioid use disorder. Those are buprenorphine, methadone, and naltrexone. And these 3 medications, they do reduce the risk of overdose death. They increase treatment adherence. There is improved treatment and recovery outcomes. SAMHSA has released clinical guidelines for treating pregnant and parenting women with opioid use disorder in their infants, and that's the hyperlink there on the screen. So the federal government is firmly behind MAT, and so that's the behavioral health side of things. But now we also go to what else is successful, and we know family drug treatment courts are specialized courts for parents with substance use disorders. ACF, SAMHSA, and DOJ provide federal funding and support, and the evidence that we receive back is that that family drug courts are effective. People like them, and so that's a promising practice. And even municipalities who can't afford to fund a full drug treatment court are adopting some of the practices of family drug courts and incorporating them into just family court with success. The other program we want to highlight is the Kentucky Sobriety Treatment and Recovery Team, the START program, and I just lifted this straight from their website. It's an intensive intervention that integrates addiction services, family preservation, and community partnerships. The program aims to reduce child abuse and neglect, improve treatment rates for substance use disorders, and build parenting skills and resilience, and increase the community's capacity to address substance use and child maltreatment when they take place in the same environment. And on the screen is the hyperlink for Kentucky START. So beyond those, and there are other, treatment modalities and programs that are working, right? And so we just thought about some other examples and opportunities to support parents with a substance use disorder. So we need to promote more active partnerships between substance use treatment agencies and child welfare agencies to enhance treatment engagement and recovery support so they can collaborate better. It's real important for us to align stakeholder roles and perspectives on the efficacy and effectiveness of medication-assisted treatment. The essential psychosocial components that need to go along with MAT. MAT is not just a prescription. It's not just another pill. The psychosocial component is extremely important, and recovery supports needed by families in the child welfare system, all of that goes together and helps parents succeed. We want to also consider the development of innovative home visiting models that focus on engaging parents in substance use treatment and provide recovery support, if possible, avoiding the need for child welfare intervention. We want to keep families together where it's possible and the child can stay safe, and mom or dad or whoever the caregiver is can get treatment. And we want to consider the potential utility of other substance use treatment modalities, such as sober living homes and other recovery housing models during and following formal treatment. So that's my presentation. Thank you. If there are any questions, please put them in the chat box.
Excellent. Thanks, Annette. Great presentation. So much helpful information. Go ahead and mute that line a little bit. Everybody, there are a good number of questions related to the data. One thing to note is that we have provided a link to the study, and so that is the fuller presentation of that research that Annette is presenting. So we'll include that in the follow-up email that we send to everybody. Now it's my pleasure to welcome Jill Kingston to present on the work of Bridget's Path. Jill, go ahead.
Hi, thanks for having me and allowing me to share what we're doing at Bridget's Path. And thanks, Annetta, that was great information. I love to learn about what's happening across the country because sometimes I get stuck in my own little world of what we're doing here at Bridget's Path. So to begin, I wanted to kind of give an overview of what is neonatal abstinence syndrome, and also known as NAS, and what the history of what we're doing here at Bridget's Path. But neonatal abstinence syndrome is a condition or a group of conditions that are caused when a baby goes through withdrawal or after he's been exposed to drugs illegal drugs or legal prescribed drugs in the womb. And in Ohio, we had, in 2015, the latest data we have in Ohio, we treated 2,174 babies in the hospital with neonatal abstinence syndrome, and it cost the system $133 million. So we know that this is a big dollar amount that for caring for these babies. I'm asked a lot, how does NAS affect babies? And what we see a lot in NAS babies is sleep problems, tremors or shaking. Some babies have had seizures. You'll hear a baby crying and it's a higher pitched sound. They have problems with digestion issues, so they have diarrhea, vomiting, often have breathing problems, the difficult feeding, which in the low birth weight, and they're just overall more irritable than a normal newborn. And one thing that you will see is that the babies have stuffy noses or they sneeze a lot, which when you see a little newborn sneeze, it's cute, but when you see them do it over and over and over again, it gets really concerning. And then you see the babies sweating, and then they suffer from dehydration from these issues. One of the things that we look at is what the effect on infant mortality is. And in 2018, Ohio was the 11th highest rate of babies dying before their first birthday out of 50 states. So Ohio is really trying to address infant mortality and then kind of seeing how it links in with neonatal abstinence syndrome. Right now, I'm asked a lot, where are these babies cared for? Where are they treated? And currently across the U.S., they are cared for by neonatologists, nurses in a hospital setting, so in a NICU, neonatal intensive care unit, or in a special care nursery. But babies right now stay within a hospital setting to go through that withdrawal. And in Ohio, symptoms are normally treated with morphine or methadone to step them down from the exposure that they had in womb. So a little bit about my background and history with Bridget's Path and how this got started. 5 years ago, my family, we started fostering, and every baby that you see there has suffered from neonatal abstinence syndrome. And that's how we were even introduced 5 years ago to this growing epidemic. We had no idea, even through our foster care training, no one had talked to us about this. And we had to learn on our own how to care for each one of these babies and how to go through the special needs that they have, even though they were treated in the hospital, that, you know, the continuing care that they need is really high. So we began fostering, and this is our family today. And we are still fostering, and we have adopted one of our little girls. But through fostering, my eyes were open to a whole new world of what families were struggling with. We were seeing family bonds being broken with the babies that were being placed in our home. And we were seeing the foster system, the burden that was growing on them, and the caseworkers. The cases may not have increased, but the demand on the need for the care for each family was increasing, and we were watching moms and dads struggle, grandparents struggle, caseworkers struggle, and I just thought there has to be a better way. There has to be something in between what happens in the hospital and going home with family, and that's how the dream of Bridget's Path began. I found Lily's Place in West Virginia trying to open, and I contacted them and asked to come see what they were doing. They are the first newborn recovery center in the U.S. And went there, and leaving there, I said, oh my gosh, Dayton, Ohio needs this. And came home and just really started connecting with people in the community to start Bridget's Path. We're located in Kettering, Ohio, which is just about 5 minutes south of Dayton, but we're about 45 minutes north of Cincinnati for those of you that are familiar with the Cincinnati area. So that's very close to us as well. Our mission is really to provide the inpatient level care for the drug exposed newborn. So for the baby that has to go through that withdrawal, we can provide that at Bridget's Path. Instead of the baby staying in the NICU, they can come to Bridget's Path, go through that withdrawal. And what was really important to me is having a non-judgmental setting for our mothers. There's so much stigma, there's so much guilt, there's so many things that moms are facing. And so I wanted to create a place that we could support the mothers, that we could, and fathers. I say mothers just because it's a newborn and we know mom and baby come together, but dads, families, and really provide the educational services that they need. And as we've worked with families, we've really learned what their needs are and what else we can do. So I'll walk you through our center a little bit. We're very family centered. We wanted to create this is the lobby when you walk into Bridget's Path, and we wanted to create a clean, safe, welcoming, feels like home when you walk in kind of atmosphere, so that moms have a different experience than when they walk into the hospital. Our nursery areas, we have 4 of these nursery areas, and each nursery area has 6 individual rooms, baby nurseries off of that nursery area. And this area is really a place where we have clinicians who take care of the babies, who really have a special love for babies with NAS and their families. We really encourage maternal bonding in these areas, and we're able to really model how to care for babies. So if we have moms that haven't parented before and haven't had modeling of how to care for a baby and bond with a baby, we're able to do it in this really family-centered atmosphere. This is an example of one of our private nurseries. This is important for low stimulation. We're also able to bring it's kind of a stretched out picture, but babies, or the moms can have a bed in here next to the crib. I don't have a picture of that, but we do have moms who stay overnight, and dads on occasion that stay overnight so that they can be bedside with baby and really have that experience of what it's going to be like when they go home. We're able to have that low stimulation atmosphere where there's no loud beeps and buzzers like there is in a NICU. We are able to really focus on that individual care of that baby, so we can have immediate diaper changes, on-demand feeding. We're able to have kangaroo care with mom so that she can really have that bonding. We encourage breastfeeding. So these individual rooms really give that privacy to that mom, but also have the quietness and the low stimulation that these babies need as they go through withdrawal. There's examples of some of our other nurseries. We have 24 of these nurseries in our facility. Each nursery was decorated by somebody in the community, and that's how we raised the money to redo our facility. We had to completely go from ground up to build our facility. This is an example. It's right off the nursery area. It's one of our bathing rooms, and our babies, when they're going through withdrawal, one of their favorite things is to sit in the bathtub and relax. And we are able to have when moms are there, provide all the care for mom. So if mom is there and says, I want to go give my baby a bath, she goes and gives her baby a bath. She does all the care for baby while she is at Bridget's Path, so that she can have the support from our nursing staff, but also to just be able to be a mom while she's there. So I've talked about some of this, and this is how Bridget's Path helps our babies. We have, right now we are staffed to have 8 babies in our facility. We are privately funded, so we have registered nurses and patient care assistants who care for our babies 24 hours a day. We use medicine to help them withdraw, and we really create individual care plans for each baby. Every baby has been so different than the next, and we're able to create that individual care plan so that we can work with the family to know what that baby needs when baby goes home with family. We provide a home like private nurseries, like I showed you, with the low stimulation and the non-pharmacological care, which is the kangaroo cuddling. We have cuddlers in the building 24 hours a day, so when mom can't be here, that we have someone to rock babies and help with that. So that on-demand feed, small feeds, is really important for these babies. And then having the consistent caregivers and being able to encourage that maternal bonding is really important. We see that when moms are involved and when moms room in, they do, the babies go through withdrawal so much easier. And when we have a mom that is walking in the room, you can see the baby just relax when mom's there. So we encourage that in every possible way. So one of our really important parts of Bridget's Path is not only getting that baby through that withdrawal, but it's really surrounding that family with support. We provide strength-based family advocacy. So we have family advocates who work with the family. They do care coordination from their doctor's appointments to their, Annette talked about the working with child welfare and the substance use treatment providers and family drug courts. We work with all of them. We're kind of that in-between advocate for the mom. So what we've seen is our families are really getting a lot of pressure from so many different systems. And what we do is we help her break down and prioritize what she needs to do to succeed, using her strengths that she has with mom, or if it's dad or family member. So we really work with them to really pull together the child welfare system, the treatment providers that they're working with. We have a great family drug court in Montgomery County where we're located. Our moms voluntarily join that so that they can stay in custody of their child. One of the things that our goal is to really strengthen our families and that non-judgmental support for our mothers. And when we created Bridget's Path, trying to figure out a way to fit us in licensing in the state of Ohio was very difficult legislatively, because there's nothing like this that exists. So we had to become licensed as a Children's Crisis Care Center, is what it's called, facility. And what is good about that is that we are able to allow families to stay in custody of their child while they are at Bridget's Path as a Children's Crisis Care Facility. So originally, when we decided that, where we were going to fit, and then we started treating families, we did not realize the length of stay for babies was going to be much different than what you see in the hospital. We thought we would get them through the withdrawal part and then babies would go home. But what we're seeing is that the importance of that, the social part, the psychosocial support that the families need, and the what they need for housing, for recovery services, for education, all that, those resources that they need are so important. And we are able to allow babies to stay here up to 90 days for social reasons, which allows that mom really to get on her feet, find sober living, and get connected to the job, the housing, everything that she needs, education, whatever her personal plan is, we're able to support her through that while baby stays with us, so that baby does not have to go into foster care. And we've had so far 100% success with no babies having to go into foster care by supporting the family. Not 100% have all been able to go home with moms, because mom's still working on some sobriety, but we've been able to either place with kinship or half of our cases, we've been able to have babies go home with mom on a safety plan. So it's been, and we continue to work with them even after baby goes home from Bridget's Path. But we really work on connecting the family to all the resources in the community so that she can continue in her recovery and have the support from all the different resources that we have. And we have really great resources. It's just the most difficult thing is getting everybody on the same page to work together. And how one thing was important, the reason I even, had this dream to create Bridget's Path, I saw the breakdown in the family and which directly affects our community. So we help the community by, having better outcomes for the babies that have NAS in their families. Our goal really is to strengthen families so that they can be contributors in our community and be successful. So we are partnering with organizations to provide that continuum of care. We partner with the hospital systems. Our local children's hospital has been a huge partner in helping us get Bridget's Path up and running. And then we have two other larger hospital systems that we partner with in the Dayton area. And then working with children's services, the treatment providers, and then the drug courts have been absolutely a great partnership, and working with all the different social service agencies to, have that continued early bonding and keeping mom and baby together has been very successful this far. And then we've teamed up with a lot of faith-based and the social action groups to help support these families through recovery and have great success. I'm often asked where we get our name, and Bridget is a patron saint of newborn babies, and so that we were looking for a name that really embodied who overlooks and watches over babies. And then Path comes from Psalm 25:4, which is "Show me your way, Lord, teach me your paths." And this was, for us as leaders to, be able to know what path to follow and how to where to go next. And then for me, it's been a huge faith journey through this whole process. And then as our families leave Bridget's Path, that they have a new path in their life and they feel strengthened and empowered. So we're often asked about, what have we had to do and how do we pay for this? And we continue to work at the state and federal levels for to look at funding strategies and what we can do. Since this epidemic came on pretty quickly, there isn't something that you can say, a newborn recovery center can do this and here's how the funding works. So we're really working at both levels to figure out how we can support these families to move forward. But our biggest contributors have been private donors. We've been able to raise close to $4 million to be able to care for the babies in our community, which includes the state contribution from a community fund that we have. And then the local hospital support and the community partners have been amazing. Our community has been hit hard in Dayton, Ohio, often seen as the epicenter of overdose capital. And it's hit me personally. I've lost my cousin a year ago to overdose. So we, from our community, the prayers, the advocacy, financial donors, and then the connections and just spreading awareness has been a big part of getting Bridget's Path to where we are today. We started seeing babies in January, so we are going into our 7th month of operation and have had huge success with the local support that we've had. And we were on the Today Show about a month ago and got a ton of calls from people across the U.S. asking how they can do this in their community. And the biggest thing that I've seen is just building that local community support, getting the hospitals, rehabs, churches, the community groups the foundations and working with every level of people coming together to really try to find how to rebuild the community. And for me personally, it was finding that the way to rebuild and strengthen families, and working with 2 generations, the babies and the moms and dads, and a lot of times 3 generations, because we're working with the grandparents as well. There's a lot of grandparents who are parenting newborns now, and so really trying to just rebuild the family to strengthen them, empower them, and help them feel that like they can handle everything that they're faced against. And then working at the state, working in the state departments, the regulators and legislators has been a huge part of what we've had to do to figure out who will regulate us, what will we be licensed as, and that's one thing I've learned too, is every state is so different. So I have people trying to replicate in other states, and they're kind of starting from ground zero because each state is so different. Lily's in West Virginia has been in operation for, I think, 4 years now. So they've been very successful in what they're doing. So I would love to answer any questions at the end of this, and you can always reach out. Here's our contact information. We're also on Facebook, Twitter, and Instagram. We have a big social media following that's helped us get where we are today. So thank you for learning more about Bridget's Path, and I'm always happy to answer questions.
Jill, thanks so much for that amazing presentation and the work you guys are doing. A lot of commenters are just grateful for the work that you guys are doing and the amazing activities that you're participating in, how you're supporting mothers and children. Everybody, we're going to turn to Lori Currier next from the call. We're going to go a little bit over on our webinar time today, but it's so much great information. I hope you guys are enjoying it as much as we are here and just hearing about this great work that's being done. So we will go a little bit over. So if you'll stay with us, we will get to Lori's presentation. Lori, are you there? Lori, we can't hear you. If you can come off mute.
Aha.
There you are.
Excellent.
Lori, we're excited to hear from you and the work that you're doing with the call. Go ahead.
All right. Well, thanks so much for inviting me to join in today. And Jill, I want to thank you so much for the incredible work that you guys are doing and for your serving families. That's very near and dear to our heart here in Arkansas and at the call. And so this afternoon, I wanted to start by sharing a little bit about our organization and what we're trying to accomplish. So about 10 years ago, we started the call with a vision to have no waiting children in foster care. And basically what that means is that we need to have more than enough foster and adoptive families for children in their local communities. And so that's really the goal that we're reaching out for. And we're going to do that by educating and equipping and encouraging the Christian community to provide the future and a hope for kids who are in foster care in our state. Currently, the need in our state is we have about 4,600 children and youth who are in foster care today. We have about 1,700 open homes to care for those children, but there's still a gap between the number of homes that are available and the number of children who are in need of homes. So what we're doing is we're looking to the local church. There are about 5,900 churches in Arkansas, and we often say that if one family from every church came forward to foster or adopt, we would very quickly solve the problem that we have in Arkansas. Currently, about 50% of the children and youth in Arkansas above the age of 6 live in group settings. They live in group homes, congregate care situations. And so we've decided that we have a goal of raising up an additional 3,600 foster homes to be able to meet the need and get every child in a home that they deserve. Some children obviously do better in therapeutic settings, and we certainly support congregate care facilities that are providing that type of service. But we know from research that has been done by the Annie E. Casey Foundation that children do better when placed in families, and so that's a goal that we have in our organization. So the problem that we have in foster care is really a community problem. There aren't enough foster homes. There aren't enough adoptive homes to care for the children who are in care. And we see the solution to the problem as engaging the faith community. And for us, that's the Christian community. But there are other organizations in our state that are similar to us that engage different kinds of faiths in the foster care situation here in our state. There are these are the top 3 reasons that children are entering foster care in Arkansas. 53% are coming in because of substance abuse by their caregivers. Often that substance abuse will contribute to neglect and also to parent incarceration. So none of these there are usually multiple reasons why children and youth come into care, and these are the top 3. And that to me, when I look at those, I think that they're just all completely interrelated to one another. So one of the things that we're trying to accomplish in Arkansas is bridging the gap between the church and the state. For us, there are as I said, 5,900 churches in Arkansas, but sometimes the church and the state don't talk to each other very well. They don't understand each other. And so what we're trying to do is kind of be a navigator of the system and to be a connector between the churches and the state agency, to be a helper, to kind of walk alongside families and help them as they go through the process and really kind of decode the mystery or demystify that situation. So that's the reason that the call really exists, is to help facilitate good communication between the church and the state agency. Our partnership is with the Division of Children and Family Services, which is the child welfare agency here in Arkansas. And the call itself is, in the state of Arkansas at least, has an unprecedented relationship. No other organization has had the type of relationship with DCFS that we have had in the state of Arkansas. We are not an agency. We are not licensed as a placement agency. We just walk alongside DCFS. We walk alongside the church and all the families that we recruit and train and support so that, as I said, to sort of demystify the process and provide the supports that are necessary. We take no contract money from the state of Arkansas. We're also privately funded. And what we've done is developed a model for working together with DCFS. We have a model that we use in working with our affiliates and then we have a method for working with DCFS that is very specific. We have well-defined roles and responsibilities. Our responsibility as the call is to focus on the churches, to focus on recruiting, training, and supporting families. And DCFS is responsible for determining whether our families that we recruit are appropriate to serve children in foster care, and then they make all decisions related to child placements. So our strategy, as I mentioned, is to recruit, train, and support. And we do that with families, foster families and adoptive families, and we do that with volunteers. The call is really a volunteer-driven organization. We have 40. We've actually grown now from, I think you said 44 in the biography this morning, but we're up to 46 counties, and we have an additional 10 counties that are emerging across the state. And really what that means is we have 46 affiliates or 46 counties, 33 affiliates that are using our model for how we work with DCFS to recruit families from the church, train those families, and move them along in the process. Those 10 emerging counties are counties that are just learning how to be the call in their area. And once they are ready to launch, then they'll begin to focus on the community problem that they have to solve the need for foster and adoptive families in their home territory. So over the past 10 years, we got started in 2007, so I guess 11 years now. We have been able to open really getting close to 2,000 families. We currently have 730 foster homes that we're serving in Arkansas. That represents about 67% of the traditionally recruited, not kinship care, but traditionally recruited families. More than 900 children have been adopted into forever families, and more than 11,000 children over that period of time have spent time in families that we have recruited and trained and currently support. So in Arkansas, we haven't had a huge impact from the opioid crisis, but that impact that we have had continues to grow. And one of the things that I noticed as I was going through the research and kind of looking at what's going on in our state, there is a correlation between the number of opioid prescriptions per capita, the number of NAS births, and the population of youth in foster care. And so in a 4-county area, and I don't have the map for you, but it was shown earlier, there is a high incidence of opioid prescriptions and NAS births, and then population in Arkansas. Interestingly enough, that area of the state, that 4-county area of the state, has the very highest population of kids in foster care. And oftentimes when we talk about foster care, just what is the situation across the state of Arkansas, we focus on that area with the highest number of kids in care, and people always ask, what's going on there? Well, I think it's a lot of things. I think it's substance abuse and parent incarceration and just lots of different kinds of things, which tells me that it's a fairly complicated problem, but it really needs a significant focus on that part of the community, the local community, to solve it. So that's a great transition. So foster care and the opioid crisis. Well, we know that the foster care problem is a community problem that local communities need to own. In our case, really across the state of Arkansas. It's best solved in a local community. We want to make sure that local children have the opportunity to stay in their local communities so that all the things that they're familiar with, their schools, their friends, their church, or faith community, all the connections that they have in their community are very important, and we want to try to preserve those the best way that we can. When we don't have families available to take children in from their local communities, then we create further trauma for children. So since we have a community problem, guess what we need? We need to have a community-based solution to that problem. And we've already talked about it today, how important it is for our communities to rally together, not just the faith community, but also the business community and lots of different elements of the community to rally together to solve these problems. Community partnerships are hugely important. One of the things that I've learned over the 10 years that I've served with the call is that partnership can be difficult. And a lot of people just don't want to deal with the issues around developing community partnerships or collaborative partnerships of any kind, but they are so valuable. And the reason that they are is that I'm assuming that there's a continuum of care that needs to be met. And that's true, I think, for the opioid situation, for the foster family situation, for the incarceration situation, people that are actually being released from prisons back into the communities. All these things are related, and they're all on a continuum. And so we can't all do everything, but we can all do something. And so if we look around in our communities and we see, well, there are things that we can do to make a difference, one little difference, but then we unite with other people and other organizations and other communities in our community to really have a larger impact. So that's the value of collaborative partnerships. But I have to say that the key to those partnerships is really good communication, being very proactive, and just being really honest with each other about what we can do, what we can't do, setting high goals, and doing the best we can to achieve those. So those are the things really that contribute to that success. So for us, engaging the faith community is crucial, and I think that that's really true across the state of Arkansas. A few years ago, the governor of Arkansas, Asa Hutchinson, called together the faith community across the state of Arkansas to focus on two issues. One of those was foster care. The other was folks who are being released from prison. And so he called all faiths together for 2 days of inspiration and equipping to talk about, what are the needs of these populations and how can the faith community really get engaged with helping to solve local problems in their community. And the response to that has been incredible. They've since repeated the conference, and it will be happening every other year in the state of Arkansas so that we can keep our eye on progress in the engagement of the faith community across the state of Arkansas. So why is it important for faith communities to engage in these areas of foster care and of substance abuse recovery? A lot of issues related to foster care and recovery are as a result of disconnection, of isolation, of there being hopeless situations, lots of pain and trauma. And what the faith community offers is a place where people can go for help, where they can belong, where they can experience joy and hope and connection. And as a result of that, healing. Really, it's been mentioned several times today, the key to solving these issues is healing these families forever so that they break generational cycles of abuse and neglect. And the church or the faith community at large, for me, it's my church, are great places for us to start. We're already providing services. We're already reaching out to help people in our communities. And so that's a great place for these movements, these types of movements to start. So one of the most important things that communities can do is provide support for families. And really that support can be extended to people from all over the community. So there are lots and lots of people who, so for instance, child welfare workers. I just recently had a conversation with some caseworkers who shared that dealing with families who are dealing with substance abuse is difficult because it can often be frustrating, and they often don't have the equipping that they need to feel like they're doing a good job. They need education, but they also need support in their work. Families obviously need support, foster families, adoptive families, bio families who are engaged in the foster care system, those who are suffering from substance abuse, all of their families. It's really a family problem. And so what we want to do is address the issues of the family and those who are surrounding the family in these situations. And that can include, law enforcement has been mentioned, government, education, teachers a lot of times are aware of things that a lot of other people are not, the medical community, the mental health community, recovery and treatment communities, obviously the faith community. And I think nonprofit partners are really beginning to play a significant role in these, in the success of support that's happening around our state, and I think around the nation as well. Training is hugely important. The one thing that that we all need to understand is that none of us are immune from the ravages of addictions and the things that cause our children to come into foster care. And so we need to be aware. In Arkansas, we were not aware, especially in the faith community, of the needs of children in foster care. And so therefore, children were really going without families that they needed. And so just making sure that everyone is aware that there's an issue in our community and be informed about that, and then be proactive and figure out what are the next steps that need to be taken. Look at that continuum of care and decide, is there something that I can do? Is there a role that I can play in that? Be proactive. Well, think about prevention. That's really important. And a lot of times we focus our attention on prevention to children. We say don't do drugs, right? But really what we need to do is we need to focus on parents so that parents are in the loop and they understand what is going on in our communities related to substance abuse and issues related to substance abuse. So my understanding is that Health and Human Services has quite a lot of recorded training on their website related to the issues that we've talked about today. So I would highly encourage you to go there and look and see if there's a training that would work for you and help you learn more about what's happening in your local community. So what we know about recovery and long-term recovery is that we have to have a safe and healthy community to heal and recover. And this is actually came out of a conversation that I had with a pastor friend of mine who also is the executive director of a nonprofit in Arkansas that helps those being released from prison reacclimate into their communities. And so Paul is so right about that. We need those safe, healthy communities where people can come and feel like they're being supported and wrapped around in a way that is meaningful for them and will help them be long-term, healthy in the long term. So I just thank you so much for the opportunity to be here today, and I just wanted to share with you that, I've said it before in my presentation, but I have personal experience with a family member who has suffered from an opioid abuse issue, and it's very difficult. Many of you on the call probably have had the same experience. It's getting more and more common. It's not limited to, well, actually it's affecting an entirely new socioeconomic group. And that's probably the most frightening thing about it. And so just I want to share really a story of hope. It was difficult. It was a family problem for us. Everyone in the family, got treatment, and we're all still working on that. But it's a story that ends well, and so I just tell you that to give you hope that what you do in these situations and what you do in your community really does matter. It matters to families that are on the ground. And so I commend each and every one of you who are already engaged in that, and encourage those of you who have not yet gotten engaged to please do that. If there's something that we can do to be helpful, like in sharing our model, how do we do what we do, we're just so happy to do that. And this is our contact information, and look forward to hearing from you. Thanks so much for this opportunity.
Thanks, Lori. Amazing work that you guys are doing and such helpful information. As Lori noted, there's a wide range of training and resources, both from last year and this year, that you can participate in to learn more about all this work. We have run over time. I want to thank so much of you for staying with us. We're going to share a lot of these questions that we received with our presenters so that they can follow up with some of the specific issues that have come up. Want to make sure you know about there's Annette's information and the research from ASPE is part of a broader research report that's provided in the chat feature right now. We'll include that in the email that we follow up everybody with. So that will be available. And then the contact information and the websites for Bridget's Path and the call will also be provided in the follow-up email. We hope that you know that we know that this is a crisis of hope in so many ways, and we hope this information gives you a sense of the challenge, but also the renewed and strengthened sense of hope of what's possible as we respond to this national crisis. We will be sending a link to the recording of the webinar today so that you can share it with other people if you're interested in letting them know. I want to personally thank our speakers for their insights, the experiences that they've had in Arkansas and Ohio, as well as Annette's presentation here at HHS. And to thank all of you for taking the time out of your busy day to learn more about how to bring hope and healing to your community. We also want to make sure you know that the next webinar in our series of webinars that focus on the opioid crisis will be 3 webinars that focus on prevention, addressing adverse childhood events, or ACEs, as well as teen resiliency. And so that series will begin on Thursday, July 26th at 12 at noon, when our webinars usually start. So please make sure to go and register for that webinar. And if you haven't gotten that information yet, feel free to send us an email at partnerships@hhs.gov so we can make sure you're on the list to receive the information about the upcoming webinars. Thank you so much for joining us today. Thank you to all of our presenters for this amazing information. We appreciate the work that you all are doing and the work that everyone is doing on this call out in the community. Thank you so much and have a great day.